Hi, I'm Julie Stevens. I'm a postdoctoral researcher at the VUB, the coordinator for EU COPD. I'm here with
Nancy Preston. I'm a professor of supportive and palliative care from Lancaster University in the UK, and I led one of the early work packages.
And I think we're going to talk a little bit today about one of those early work packages and how it's translating into the work that we're doing now. So right now we're starting towards our first moment of starting up the intervention in some of the hospitals that are participating in the international trial. But before that, we had, with Lancaster at the helm, we had this period of adaptation and translation for the intervention that started within a UK context.
Yes, we had meetings with clinicians, both from the hospital, from the community, palliative care, but respiratory, GPs, to try and understand how they manage and care for patients and what's lacking, what do they need. And a big element of what they needed was better communication. So conversations can happen in the hospital and they might feature in a discharge summary, but it's very brief, there's no detail. And we know from research that it's very rare that GPs and community staff even know what a prognosis is of a patient. So we felt a really important part of this was if we were going to try and encourage clinicians to have more open and honest conversations and make plans, well, we needed to document that somewhere in more detail.
So one of the first phases that we had in working towards the startup of this trial was looking at how we can adapt the intervention to these different contexts, but make sure that we're not losing the essence of what's making this intervention work and where the impact really is, which is that communication. I'm just thinking about one for advanced care planning, because that's my wheelhouse more generally, where advanced care planning and initiating it is really important, but every country is going to have some different jurisdictions, some different legal contexts around advanced care planning. Some hospitals might already have documents that they use or brochures that they use. Within the UK, it was an NHS pamphlet that they used. Is that right?
And I think it was trying to explore what was used in each country,
right,
and how well people were trained in some of these elements, and in which countries this could be almost brand new, and even in terms of which clinicians can be involved. Some countries had very little involvement in community services, so how can you manage this project and try to keep people out of hospital if you've got limited community services? So it's bringing all this together so it could work in the different settings, or could work in principle in the different settings. So there's some compromise because you're doing it across multiple countries. What might work in the UK may not work in Hungary, but trying to work out, as you say, the core elements, so that we all do those elements. So we have conversations with patients, so they have a better understanding of their illness, so we can make goals about what is their care, and these can be shared decisions. But crucially, we record them, and I think that is a really important part.
And I think one of the nice results that we had as well from this adaptation work is that we found ways, I think, within every country to make sure that all the different components are represented in some way, which, especially if you're thinking about settings where the integration of palliative care into respiratory care for these patients with advanced COPD is still in earlier stages. Finding ways to make that possible, I think, is really, really encouraging for this trial that we have going ahead. I think the other encouraging part about doing this trial now is that we're really starting to sit together with these hospitals that are participating, that are getting ready to do the intervention, and looking at how we're going to make this concrete, even on a more granular level, with these care teams, looking at how we can compose them, who is already involved from respiratory care, from palliative care, but also more broadly, people maybe who are regularly involved from physical therapy, from psychologists, social services, social workers. So there's really a lot of room to involve people who are already in some way involved in the care for people with advanced COPD, and looking at how we can facilitate the ways that they work together to care for the same patient.